Rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder predominantly of the joints but with many systemic manifestations of chronic inflammation. The cause is unknown, although there is an association with specific HLA types. As with most autoimmune diseases, rheumatoid arthritis is more common in women. Chronic synovitis leads to overgrowth, or pannus formation, which damages all the structures surrounding the joint: bone, ligaments, tendons, and cartilage. Presentation: bilateral, symmetrical joint involvement, PIP joints of the fingers, MCP joints of the hands, and involvement of the wrists, knees, and ankles. Morning stiffness lasting at least 30 minutes, rheumatoid nodules 20%, ocular symptoms, episcleritis, lung involvement, pleural effusion, vasculitis, skin, bowel, and peripheral nerves, cervical joint involvement, particularly at C1 and C2, pericarditis and pleural disease, carpal tunnel syndrome. Morning stiffness of multiple small, inflamed joints is the key to the diagnosis. Diagnostic tests. Rheumatoid factor (RF) in 70% to 80%. RF is rather nonspecific and can be associated with many autoimmune and chronic infectious diseases. Anticyclic citrullinated peptide (anti-CCP) is more than 80% sensitive and more than 95% specific. Radiographs: 1 erosion of joints, 2 osteopenia. Anemia, normocytic arthrocentesis is useful on initial presentation to exclude crystal disease and infection. If the diagnosis is not clear, will find modest elevation in lymphocytes, elevated ESR or C-reactive protein. Abnormal X-rays are no longer needed to establish a diagnosis of rheumatoid arthritis. Instead, diagnostic criteria are assessed on a point system. A total of 6 or more points equals RA, joint involvement up to 5 points, ESR or CRP 1 point, duration for longer than 6 weeks 1 point, RF or anti-CCP 1–3 points. Treatment: methotrexate. Methotrexate is the best initial DMARD. Adverse effects are liver toxicity, bone marrow suppression, pulmonary toxicity. Tumor necrosis factor inhibitors: infliximab, adalimumab, etanercept, golimumab, certolizumab. Tumor necrosis factor (TNF) inhibitors are the first line as DMARDs for those not responding to methotrexate or intolerant of methotrexate. They are often used initially in combination with methotrexate to prevent disease progression. TNF inhibitors are safe in pregnancy. Hydroxychloroquine. This agent can be used as monotherapy as a DMARD in cases of mild disease in which we wish to avoid the toxicity of methotrexate. More often, hydroxychloroquine is used in combination with methotrexate as a DMARD. Rituximab. This agent, originally developed for non-Hodgkin lymphoma, is effective in rheumatoid arthritis as a DMARD by removing CD20-positive lymphocytes from circulation. This leads to excellent long-term control of rheumatoid arthritis. Rituximab is used in combination with methotrexate in those not responding to anti-TNF medications. Sulfasalazine, leflunomide, abatacept, and anakinra. These agents are alternative DMARDs to add to methotrexate if anti-TNF agents do not control disease. Symptomatic control of rheumatoid arthritis. NSAIDs are the best initial therapy for the pain of rheumatoid arthritis. They work immediately to improve inflammation, but do nothing to prevent the progression of disease. Steroids also work in a matter of hours to control the pain of rheumatoid arthritis secondary to inflammation.